My last question to you is that, how does 2021?
Please mute, unmute. Unmute.
So welcome back once again. We begin this session by introducing our chair for session 2. It's my pleasure to introduce Dr. Junaid Khan, who holds the chair of the 10th International Neonatal Conference. Welcome, Dr. Junaid Khan, please.
Okay. Thank you, Mohammed, once again. So we'll start our session, and it's my honor to introduce Professor Peter Davis. He's the professor and director of neonatal medicine at the Royal Women's Hospital in Melbourne. He has led the Department of Newborn Research since 2009. He completed his graduation from the University of Queensland and a fellowship from McMaster, Canada, an interest in clinical epidemiology and evidence-based medicine. After returning to Australia in 1993, he was appointed as a consultant neonatologist at the Royal Women's Hospital in Melbourne. He leads a team of enthusiastic clinical researchers interested in improving the take care of the babies in the delivery room and the intensive care unit. He's a substantial contributor to the Cochrane collaboration and a member of the neonatal subcommittee of ILCOR, which is the International Asian Committee on the Resuscitation. And it is not a coincidence. Whenever I talk, I cannot complete any of my talk without his one of the reference from him. Okay, and today I'm going to do it again in my talk in this session. All to you, Dr. Peter Davis.
Thank you. Slide.
Thank you, Junaid. Developments in our understanding of cord clamping and lung aeration. And I'd like to start by paying a debt of gratitude to my colleague, Stuart Hooper, a physiologist who's really revolutionised the way we look at this important transition from fetus to newborn. We're particularly going to look at the cardiovascular changes and the respiratory changes, and most importantly, the combination of those two systems, how they change together. I'd like to convince you today that delayed or deferred cord clamping is more than just a placental transfusion to the newborn baby. So for quite some time now, we've recognised that delayed cord clamping for at least a minute after birth is the most appropriate way to manage term babies not requiring resuscitation. That directive has been with us since 2010. So turning our attention to the group of vulnerable infants, those are the preterm babies, there's been an increasing amount written about these babies. And when we looked at the literature in 2015, there were 16 articles, 12 randomised trials, 4 observational studies with more than 1,000 babies in total that looked at this question: when should we clamp the umbilical cord of a preterm baby? The important thing to realise about these articles that all of these studies excluded babies who needed resuscitation. Now, when these articles were looked at, there was no difference between the groups in terms of their mortality or rates of severe intraventricular hemorrhage. There was no evidence regarding neurodevelopment. There was a suggestion that delayed cord clamping reduced the risk of any intraventricular hemorrhage, and it improved hemodynamic stability for preterm babies in the first hours of life. They seem to need less inotrope support. So at this time, we made a fairly weak recommendation. We suggested delayed cord clamping for preterm infants not requiring immediate resuscitation. That's a weak recommendation, and it's based on very low quality evidence. Since then, we've had a new large randomized trial that's added to the evidence base to help us understand this question. And this has been brought into the overall body of evidence in a recent meta-analysis. And we can see that when delayed and early clamping are compared with respect to the important outcome of mortality, there is now a statistically significant benefit to delayed cord clamping. It produces a 32% reduction in mortality. The confidence intervals don't include treat one baby with delayed cord clamping and you'll prevent one death. And this statistic here, the I-squared statistic, tells us the results of all of the trials making up this pooled analysis are consistent with one another. So this is good quality evidence. So if we look again at the physiology and the changes that happen at birth to the circulation, if we start with the fetus, and you'll remember that blood returning from the placenta mixes with that from the lower body, goes through the ductus arteriosus, and whereas it would normally go to the right heart, it is generally shunted across the foramen ovale, across the atrial septum and into the left atrium and then the left ventricle. From there, it's pumped into the body, the upper body, and back to the lower body and the placenta. The small amount of blood that does come back to the right heart is largely shunted across the ductus arteriosus. So the lungs, not being an organ of gas exchange at this point and being fluid filled, receives very little in the way of circulation. And shortly after birth, the fetus moves to the adult pattern of blood supply, where blood returns from the body to the right side of the heart, pumped by the pulmonary arteries to the lungs, returns through the pulmonary veins to the left atrium, to the left ventricle, and then pumped out to the body. So we've got two very different systems. The adult, the two sides of the heart functioning in series, and in the fetus, the heart, two sides of the heart functioning in parallel. What I'd like to focus on is where the left ventricle gets its blood from. In the adult, the left ventricular preload comes from the lungs, from pulmonary veins, draining the lungs, left atrium, left ventricle. For the fetus, the left ventricular preload comes from the umbilical venous supply, returns through the foramen ovale and into the left atrium and then to the left ventricle. So the interesting thing about that is that the left ventricular preload in both the adult and the fetus comes from the organ of gas exchange. In the adult, the lungs; in the fetus, the placenta. So then we have to consider what happens when we clamp the umbilical cord after birth and what the effects are on the cardiovascular system. There's lots of changes going on as this fetus becomes a newborn, and after birth, the left ventricular preload must switch from the umbilical veins to the pulmonary veins. And that means that the lungs have to aerate, they have to expand, and in doing so, the pulmonary vascular resistance has to fall. So it therefore follows that if you clamp the cord before the lung aerates, there is an immediate reduction in left ventricular preload and also an increase in left ventricular afterload, causing a decrease in left ventricular output. And this is a bad thing for the newborn baby that's struggling to adapt to outside life. This has led us to think about the timing of cord clamping and to suggest that it maybe it shouldn't be based on what the clock says, wait 30 seconds or wait a minute. Maybe it should wait on what the baby is telling us. It should be based on the baby's physiology, so that we should wait until the lung aerates and the pulmonary blood flow increases before we clamp and cut the cord. That way, the pulmonary blood flow is able to immediately take over the role of providing preload for the left ventricle following cord clamping. So the next question is, if delayed cord clamping is good for normal babies, what about babies who need some help, need our help aerating their lungs, need help with their breathing, they need resuscitation? And the logic here is that by establishing lung aeration before we clamp the cord will make a difficult situation better for the babies. And so the question then becomes, can we actually administer newborn resuscitation while the baby is still attached to the umbilical cord? I'd just like to show you a video to illustrate that, yes, this is possible. So this is a term baby being delivered. Just going to stop it there. We've got a researcher and a paediatrician scrubbed into the field. The clinician has a bag and mask that has been sterilised, and between the T-piece and the mask, we have a device here that will measure tidal volume and measure carbon dioxide being excreted by the lungs. So the baby comes out. We're going to measure the heart rate using ultrasound, and it's quite good at the beginning of the resuscitation. It's 132 beats per minute. Just need to straighten out the umbilical cord so it's not under any tension. And having been quite active and vigorous early on, at about a minute of age, the baby suddenly becomes quite floppy, stops breathing. The heart rate drops a little bit from the high 130s down to 120s. And in spite of some stimulation, the baby doesn't respond. So we start giving some mask ventilation, measuring the tidal volume, measuring the carbon dioxide, standard pressures 30 on 5, giving a tidal volume of 4 mils per kilo. So that should be sufficient. Initially, we see no carbon dioxide coming back, but within a couple of inflations, we do see some CO2 returning. The baby starts to cry, starts to move. Heart rate is now back up to 140. So we give the baby another minute after we've seen carbon dioxide coming from the lungs, and then we clamp the cord, cut the cord, and the baby lives happily ever after. So it is feasible to initiate resuscitation while the baby is still attached to the placenta via the cord. It's possible. We don't yet know that it is a better way of resuscitating babies, but I've flagged that as something to keep your eyes on. Now, I listened to the last session, and there was a little bit of talk about cord milking or cord stripping. This seems like a very good idea. It gives us a quick method of transferring blood to the newborn baby prior to resuscitation. So if we want to get to the baby quickly to resuscitate and we want to cut the cord quickly, then cord milking enables us to do that. When we looked in 2015, there were a small number of trials on a very small number of babies comparing early cord clamping with milking. There were none comparing delayed cord clamping with milking. We found no evidence of a difference in rates of death. None of these babies were followed into infancy to assess their neurodevelopment. No difference in the use of phototherapy. There was some low quality evidence showing a reduction in rates of all intraventricular hemorrhage. At this point, we suggested against the routine use of cord milking for infants born at less than 28 weeks, noting that there were trials underway that would help us decide. In the meantime, we were doing some animal work on cord milking and found some fairly interesting things. We've got 3 graphs here. This is the net umbilical blood flow in purple, the carotid artery blood pressure in red, and the carotid artery blood flow in blue. Each of these black vertical lines is an episode of milking. So the cord is being milked with each of these episodes. And what you can see is with each milking, there is a surge in blood pressure and a surge in carotid artery blood flow with each successive milk. And as Ayman said, this poses a risk to the preterm baby. This is one of the things that we believe is in the causal pathway of intraventricular hemorrhage, these sudden surges of blood pressure and blood flow to the delicate circulation of the brain. In contrast, this is a lamb that was ventilated first before the cord was clamped here. And you can see that the carotid artery blood pressure and the blood flow is very stable throughout the resuscitation and following cord clamping. Anup Kathiria did a very nice and important study comparing delayed cord clamping with umbilical cord milking and looking at the important outcome of death or severe intraventricular hemorrhage. This was done in preterm babies. The primary outcome was not significantly different between the 2 groups, although the umbilical cord milking group had a rate of 12% versus 8% in the delayed cord clamping group. The problem with this study, or the problem that this study revealed, was a higher rate of severe intraventricular hemorrhage in the most immature babies, 22% versus 6%. And at that point, the Data Safety Board recommended stopping recruitment after an interim analysis. And the authors concluded here that the centres practising umbilical cord milking should consider discontinuing this practice in the tiniest babies. Now, just going to switch tack a little bit and talk about aeration of the lung. Textbooks tell us the physiology of air-liquid clearance, and we know that that's the fundamental task of the baby following birth, needs to clear the lungs of fluid and then start to exchange blood gases. The textbooks would tell us that this is due to sodium reabsorption, sodium coming in and taking with it water across the epithelium and clearing the lungs of water. In fact, that's a very slow mechanism for clearing lung fluid and won't help the baby in the first minutes of life. The other mechanism is the squeeze that the baby goes through as in the birthing process, a posture-induced increase in transpulmonary pressure. But the most important mechanism for clearing lung fluid is the increase in pressure generating by the baby's inspiration. And this is illustrated quite nicely in this graphic. Fluid is driven down the airways, the big airways, the small airways, into the alveoli and then across into the interstitium of the lung with successive inflations. And that process happens very quickly. And then over the following 4 to 6 hours, that fluid is removed from the lungs through the lymphatics. And this gave rise to the notion that perhaps instead of giving intermittent short breaths, we should be giving babies in the first minute or 2 of life sustained inflations. And the rationale here is that if you can establish a functional residual capacity quickly, will improve the outcomes following resuscitation. And there was strong evidence at this stage from animals, in the lamb and rabbit models, that sustained inflations were safe and effective. I think I might have shown this, this image before at this meeting. This is a rabbit undergoing a sustained inflation, and you can see that this results in a slow, steady inflation of the lungs up to total lung capacity. So we fully aerate the lungs and then start tidal breathing and we've established a functional residual capacity, we can very quickly establish gas exchange. So a very promising way of doing things. Back in 2015, there were 3 randomized trials, 2 cohort studies, and the evidence was not particularly strong. There was no benefit in terms of death rate or bronchopulmonary dysplasia or air leak. There was some low quality evidence of a decreased need for mechanical ventilation. So ILCOR's recommendation at this stage was against the routine use of initial sustained inflation for preterm infants without spontaneous respirations. They suggested that it could go on in research settings. And so the values and preferences that guided this recommendation were the absence of long-term benefits and a lack of clarity on how to administer sustained inflations. And it was done in the knowledge that there was a large randomized trial underway. And this trial was the SAIL trial. It was published last year, and it includes some very valuable lessons. So it started off with this rationale that if we wanted to establish gas exchange quickly and therefore resuscitate the baby quickly, it would be good to expand the lungs as quickly as possible. If we do the physics, we know that liquid-filled lungs have a longer time constant than gas-filled lungs, and therefore it made sense for a long, slow inflation rather than short, sharp inflations. We had the animal evidence that sustained inflations worked very well, but we knew in those animals they were intubated and sedated, not being potentially vigorous and not being mask ventilated. When we started the SAIL trial, there was limited human experimental data. And most importantly, there was this geographical divide. So sustained inflations were commonly practiced in Europe, but hardly practiced at all in the United States. So there was this tension between 2 ways of doing things, and the umpire, ILCOR, was agnostic, would not really express a strong opinion either way. So the hypothesis for the SAIL study was that babies between 23 and 27 weeks who required positive pressure ventilation in the first minutes of life, that a sustained inflation, that meant 20 centimetres of water for 15 seconds, repeated at 25 centimetres if that was required, was better than standard intermittent positive pressure ventilation with PEEP in terms of producing a lower rate of death or bronchopulmonary dysplasia, measured at 36 weeks according to the Walsh definition. And this is the types of mothers and babies where we were looking at. There were very high rates of antenatal steroid use. About 2/3 of the babies were getting cesarean section. These are quite small babies in the 700 gram range, and quite a few were from multiple pregnancies. The primary outcome, death or BPD, was lower in the control group. So the control group did better. This was not statistically significant, a p-value of 0.22. Most of that difference, or all of that difference, was made up by a reduction in death. Rates of BPD very similar. Nothing there is statistically significant. Likewise, no significant differences in any of the secondary outcomes. The need for surfactant either in the delivery room or at any time during the NICU admission, no increase or change in chest compression rates, requirement for intubation in the delivery room, and then some of the NICU outcomes, necrotizing enterocolitis, retinopathy of prematurity, and patent ductus arteriosus, all quite similar between the groups. When we looked at some of the other adverse events, these were pre-specified. The one that caught everybody's attention was this one, and this was the rate of death in the first 48 hours of life, which was substantially greater in the sustained inflation group. So 7.4% versus 1.4%, statistically significant. Interestingly, no mechanism to explain that, no difference in intraventricular hemorrhage rates, no sign of more air leak in the babies receiving sustained inflation, and no early evidence of lung disease in these babies. So an increased death rate, but not explainable. So at the end of the study, we had to conclude that in extremely preterm infants requiring resuscitation at birth, up to 2 sustained inflations does not reduce the risk of BPD or death, but it might increase early mortality. So this was an important lesson, I think, for all of us, that sometimes the work that we see in the animal lab does not translate well into the human neonatal intensive care situation. So we're going to finish up with mask ventilation. That's the mainstay of what we do in the delivery room. We ventilate babies mostly using a mask. And I've showed you this slide before, but it just shows you how we collect data. We have a T-piece here, a mask, and between them, a flow sensor that enables us to measure gas flow into and out of the baby and produce graphs like this. We see a pressure curve. So we're delivering pressures of 30, a peak pressure of 30, a PEEP of 5. We're seeing flow going in towards the baby in green, and then coming out from the baby through the mask and back towards the T-piece below the line. And then that flow is integrated to give us tidal volume. So tidal volume in inspiratory tidal volume, and then the same tidal volume coming out. But that was the ideal situation. This is what we saw from time to time. We're generating good pressures, 30 on 5 as before, but we're not generating any gas flow either in or out of the baby, and therefore not effectively ventilating the baby, providing no tidal ventilation. We found this was relatively common. Quite a severe reduction in expired tidal volume was seen in about a quarter of our resuscitations. So I think this explains why sometimes mask ventilation just does not seem to work. But we now have at least a partial explanation for why this might be so. And it comes again from the animal work. And this is a rabbit model. So you can see the chest end of the rabbit here, the head end up here. You can see the trachea going here. The glottis just here is open, the epiglottis is open, so there is a clear pathway from the pharynx into the trachea, seen in close-up and highlighted in this sub-diagram. That is quite an unusual picture in the first minute or two of life. Much more commonly, we see that there is closure of the glottis and a closure of the epiglottis. So there is no connection between the trachea and the pharynx. Here's a rabbit that's being ventilated with this closed glottis, and we can see that the esophagus is becoming distended with air and the stomach is becoming distended with air. And I think this is a picture that will resonate with many of you who have been in the delivery suite and tried to bag and mask a baby, blown up the stomach and not been able to successfully resuscitate the baby. Now, the explanation for this is that it is normal for the glottis and the epiglottis to be mostly closed during fetal life. And this is what allows a pressure to develop behind the closed glottis that allows for lung growth. And it helps us remind us that these rabbit pups and our very preterm babies are exposed fetuses, and that they react in that way. Their default position is to have a closed glottis and epiglottis. Once we aerate the lung and establish regular respirations, then the glottis and the epiglottis are mostly open, and then mask ventilation will work. One of the things that was noted in the animal lab, the things that would trigger apnea and lead to unsuccessful mask ventilation were hypoxia, hypothermia, and the placement of a face mask on the face of the animal. Which brings us to our final little section and looking at what happens when you put a face mask on a preterm baby at birth. And this was some very nice work that was done by some Dutch colleagues. They looked at more than 400 babies, less than 32 weeks gestation, and found that 86% of these babies were breathing before the mask was applied to their face, but about a half of them stopped breathing as soon as the mask went on. And they found that this effect was greater as the babies became more immature. And there is a physiological explanation for that, and it's called the trigeminal cardiac reflex, whereby the stimulation of the trigeminal nerve by the touch receptors on the face can provoke breath holding, an apnea, a reduction in heart rate, and changes in blood pressure. And I think we would all recognize that this happens from time to time in our deliveries. So just to finish off, in summary, delayed cord clamping is recommended for term and preterm infants. Thinking about it, physiological-based cord clamping, waiting till the baby has established effective ventilation, might be more beneficial, and there are studies underway to assess that. We believe that this concept may be able to be applied to neonatal resuscitation and stabilisation, particularly for preterm babies, but this again needs to be tested in randomised trials. I would agree with Ayman that cord milking is not recommended for extremely preterm infants. Sustained inflations, although promising, are not the answer to quickly aerating the preterm lung. And we know a little bit more about why mask ventilation sometimes doesn't work. Airway obstruction is a common cause of this problem. And we know now that obstruction occurs at the level of the glottis and the epiglottis. So with that, I'll stop and I'll await questions later on in the day. Thanks, Junaid.
Thank you.
Slide, please.
Thank you, Dr. Peter. Questions we will take.
One moment, doctor. Okay.
Yeah. Thank you, Dr. Peter Davis. It's a really nice update on the delivery room management. We will take there are a few questions already. I have it. We will do the question answer session after all three talks of this session. So without further ado, it is also my pleasure to introduce my colleague, my dear friend from my home country, Professor Khwaja Ahmed Irfan. He's the head of the Department of Neonatology in the Children's Hospital, the Institute of Child Health in Lahore. He did his fellowship from Pakistan, and then he did his fellowship in the Royal College of Pediatrics in Child Health in UK. He's a supervisor and examiner of College of Physicians in Pakistan. He's also a member of the Neonatology Group of Pakistan Pediatric Association, and he's the pioneer to led the NRP courses and NLS courses in Pakistan. He has carried out many national and international collaborative research studies and has published research and review papers. He has authored books. His latest book just came out last year. I have an honor to have that book, edited a special issue of Pakistan Pediatric Journal also, and a reviewer for various scientific journals. His talk will be is already recorded, but for the panel discussion, he will be available. So I think we can start his talk on non-invasive ventilation.
Respected ladies and gentlemen, Assalamu alaikum. My name is Khwaja Ahmed Irfan Waheed, and I am a professor of neonatology at the Children's Hospital and the Institute of Child Health in Lahore, Pakistan. I am very grateful to the organizers for inviting me to talk on this topic of non-invasive ventilation. Before I start, let me disclose that I have nothing to declare about interest or support from any product or company. The objective of today's presentation is to refresh your knowledge and share with you different types of non-invasive ventilation, their working principle and integrated approach. I will try my best to cover this vast topic in limited time, starting from respiratory failure, practical approach to various types of NIV, and end with a suggested model for their use. Ladies and gentlemen, the basic purpose of respiratory support is to maintain adequate gas exchange in respiratory failure by choosing a method that will avoid lung damage. Now, what is respiratory failure? When is help required? What type of help is required? We must be absolutely clear before we move on. Respiratory failure is broadly categorized into two types. Type 1, in which partial pressure of oxygen is reduced below 60 millimeters of mercury when checked in arterial blood gases. In type 2, not only partial pressure of oxygen is reduced below 60 millimeters of mercury, but carbon dioxide is elevated above 50 millimeters of mercury. In type 1, since only oxygen is disturbed, the remedy is by giving supplemental oxygen. In type 2, that needs assisted ventilation to remove carbon dioxide while at the same time elevating oxygen concentration in blood. Once a newborn is put on assisted ventilation, target is set to maintain blood gases, accept mild degree of acidosis in first few days and concentrate on maintaining perfusion. In extremely preterm babies, renal bicarb loss may produce acidosis. Aim for carbon dioxide between 30 and 50 millimeters of mercury. Overventilation with low carbon dioxide is associated with an increased risk of chronic lung disease and cerebral ischemia. Therefore, technique of permissive hypercapnia may be allowed. Oxygen should be maintained between 50 and 80 millimeters of mercury, or in terms of saturation between 90 and 95%. Use lower end of range in extreme preterms to avoid retinal vasospasm and retinopathy of prematurity. Use higher end of range in pulmonary hypertension to use its pulmonary vasodilator effect. Use higher end of the range in chronic lung disease also. Only two parameters in blood gases can be controlled directly through assisted ventilation: carbon dioxide and oxygen. Changes in pH and bicarb are secondary to them. Carbon dioxide can be controlled through respiratory rate and peak inspiratory pressure. Their increase will increase minute ventilation and thus reduce carbon dioxide. Increase in flow can also affect carbon dioxide by resulting increase in pressure. Similarly, oxygen can be altered through change in FiO2, mean airway pressure, and inspiratory time. Mean airway pressure is affected by PIP, PEEP, or continuous descending pressure, or CPAP. Higher is the pressure, more is MAP, and better is oxygenation. However, certain precautions and principles need to be kept in mind, as their use in higher concentration are not without hazards. Avoid using FiO2 of more than 60% for long periods. Consider using other parameters, for example, pressure or TI, if FiO2 of 60% is insufficient to maintain desired oxygenation. Be cautious while using inspiratory time for oxygen control, as longer TI are associated with asynchrony. Broadly, assisted ventilation is divided into two types: invasive and non-invasive. Since our topic for today is non-invasive ventilation, I will not go into details of invasive ventilation. Non-invasive ventilation is of different types that include high flow therapy, continuous positive airway pressure, bi-level positive airway pressure, intermittent positive pressure ventilation, high frequency ventilation, and neurally adjust ventilatory assist, all given through nose. Before we discuss further about types of non-invasive ventilation, let me define what is meant by non-invasive ventilation. Non-invasive ventilation is the administration of ventilatory support by using nasal interfaces and without using any invasive artificial airway, for example, endotracheal tube, in a spontaneous breathing baby. A baby who is not spontaneously breathing is not a candidate for non-invasive ventilation. Now, how does non-invasive ventilation work? Continuous distending pressure exerted through NIV does the work by number one, by decreasing upper airway resistance. Upper airways in term babies are supported by superficial fascia and pharyngeal muscles. This mechanism is deficient in preterm babies. Continuous distending pressure generated decreases upper airway resistance by mechanically splinting it open and increasing pharyngeal cross-sectional area. The chest wall of preterm baby is 5 times more compliant than normal. Continuous distending pressure splints it open and also alters diaphragm shape. That increases diaphragmatic activity, thus preventing indrawing of chest wall during inspiration. Continuous distending pressure improves functional residual capacity, which results in increase in size of alveoli, improving lung surface area. Surfactant deficiency leads to small size of or collapse of alveoli, resulting in reduced FRC and increased work of breathing. The epithelium of collapsed alveoli is damaged, leading to leakage of proteins onto surface that inhibits surfactant. CPAP tends to compensate it by opening the alveoli, thus reducing damage to the alveoli and surfactant. Increase in pressure improves mean airway pressure, which in turn improves lung surface area and better gas exchange. In preterm babies, the immature lung structure with thicker septa leads to reduced lung compliance. Continuous distending pressure by helping open the lungs improves lung compliance, thus increases tidal volume for a given pressure. All the above methods improve FRC and reduce work of breathing, resulting in better gas exchange. NIV is indicated where there are signs of respiratory distress and increased work of breathing manifested as tachypnea, flaring, grunting, chest retraction, cyanosis. For example, in conditions like RDS, apnea of prematurities, abnormalities of airways predisposing to alveolar collapse, diaphragmatic paralysis, and after extubation from invasive ventilation. However, it is contraindicated where intubation is required for ventilatory assistance in frequent apneas, in upper airway abnormalities, severe neuromuscular or cardiovascular impairment wherever it is encountered. At this point, I would like to mention the signs of NIV failure necessitating need for either change in settings or change in type of ventilatory assistance. These include increased work of breathing, worsening of PCO2, more than 2 episodes per hour of apnea or severe apnea requiring bag and mask ventilation, or 3 or more episodes per hour of desaturations not responding to initial increased settings. Now, having overview of basics, let us briefly go through all the modes of NIV one by one. First being nasal high flow therapy, also called humidified high flow nasal cannula therapy. Now, what is nasal high flow therapy? Nasal high flow therapy is a means to deliver non-invasive respiratory support through the delivery of humidified, heated, and blended oxygen and air at flow rates greater than 1 liter per minute via nasal cannula. Since the nasal cannulas used are loosely placed in nares, this method is associated with less nasal trauma as compared to other types of NIV. The mechanism uses flow of gases as a primary means for ventilatory assistance. By using flow of gas at more than 1 liter per minute, it causes dead space flush out, making minute ventilation more efficient. It reduces inspiratory work of breathing. Warmed humidified gas has been shown to improve conductance, compliance, and lung elasticity. It eliminates metabolic work associated with gas conditioning and reduces the energy and water loss associated with conditioning of inspiratory gas. It provides also provides mild distending pressure in the form of CPAP. It is imperative that the nasal cannula should not obstruct more than 50% of diameter of nares, and the temperature of the delivered gas is controlled at 37 degrees centigrade. The flow rates used are a maximum of 6 liters per minute in babies weighing less than 1 kilogram and 8 liters per minute above 1 kilogram babies. Next type of NIV is nasal continuous positive airway pressure. The nasal prongs used in CPAP need to be snugly fit in the nares. It aims at producing continuous distending pressure throughout the respiratory cycle. Different devices are used, including variety of continuous and variable flow devices. CPAP uses pressure for ventilatory assistance. The CPAP is generally started at a pressure of 5 centimeters of water with FI2 of 40 or 50%, or it can also be started at a PEEP equal to the PEEP of ventilator after extubation. If respiratory distress does not improve with this or worsens further or oxygenation is impaired, pressure is increased in steps of 1 to 2 centimeters of water to reach a maximum of 8 to 10 centimeters of water. If still the oxygenation is compromised, FI2 is then increased in steps of 5%. While starting CPAP, it is important to resist the temptation of raising FiO2 before pressures for control of hypoxemia. Next type of NIP is nasal bilevel positive airway pressure. It is a bilevel nasal positive airway pressure for the spontaneously breathing neonate through the delivery of sighs above the baseline CPAP pressure. Bilevel nasal positive airway pressure, if synchronized with baby's breathing, is called CPAP. BiPAP and CPAP, though given through different machines, are similar regarding fixation at nose, gas source, pressure generator, interface device, their working principle, monitoring, and the side effects. However, they are different in certain aspects. In CPAP, there is a single level pressure during whole breathing cycle, while in BiPAP, 2 level pressures are used, which are different in inhalation and exhalation. Their difference is generally 4 centimeters of water. In BiPAP, the time duration for inspiratory pressure varies between 0.5 and 0.2 seconds, while there is uniform pressure during whole cycle in CPAP. Similarly, breathing rate can be varied between 10 to 40 cycles, while there is none in CPAP. Next type is nasal intermittent positive pressure ventilation, also called nasal intermittent mandatory ventilation. It is similar to IPPV, but is given through nose. In other words, there is respiratory rate and PEEP as well as PIP, but is delivered through nose. Nasal IPPV is a type of NIV that is typically used for patients failing nasal CPAP or BiPAP or following extubation from invasive ventilation. It has an advantage of achieving higher pressures as compared to CPAP or BiPAP, thus higher MAP and tidal volume. Primary mode is where NIPPV is used soon after birth or manual IPPV for less than 2 hours, while in secondary mode, NIPPV is employed after more than 2 hours, 2 days to weeks of extubation from IPPV. Initial PIP set is at 4 centimeter above PIP required for initial manual ventilation. While in secondary mode, PIP is started at 2 to 4 centimeter above PIP of ventilator. Rest of the parameters are similar to invasive IPPV. There are 2 more modes of NIV, which I will briefly introduce since they are still in phase of consolidation. These are known as nasal high frequency ventilation and nasal neurally adjust ventilatory assist. Nasal high frequency ventilation has been reported since 1980, primarily done in animals. It is known to cause less damage to alveoli and is highly effective in washing off carbon dioxide. Since RCT on neonates are lacking, so it will not be discussed further. Nasal NAVA is beginning to be assessed in newborns. It relies on placing a catheter similar to NG tube with 2 electrodes, one above and the other below diaphragm. that sends transdiaphragmatic potential. This enables triggering of ventilator breath with a tidal volume proportional to the magnitude of this potential. It cannot work in case of apnea as electrical activity of diaphragm is absent. It is considered experimental so far and will not be discussed further. Non-invasive ventilatory support is increasingly used in preterm infants, either as a primary mode of respiratory support or following extubation to avoid re-intubation. As compared to invasive ventilation, it is easier to use, avoids complications associated with endotracheal tube, and has a lower risk of BPD. But all NIVs have similar indications and contraindications. Then, which one to choose? Certain criteria, including effectiveness, associated complications, failure rate, and of course, availability, should be considered while choosing a type of NIV for your patient. Let's review some of the literature. Cochrane review published in 2016 compared nasal high flow therapy to other NIVs regarding its effectiveness in prevention of chronic lung disease and death. 15 randomized studies were reviewed. It concluded that nasal hypotherapy has similar rates of efficacy to other forms of non-invasive respiratory support in preterm infants for preventing treatment failure, death, and chronic lung disease. Following extubation, its use is associated with less nasal trauma and may be associated with reduced pneumothorax compared with nasal CPAP. A meta-analysis of trials published in 2017 in Journal of Maternal Health, Neonatology and Perinatology compared effectiveness of nasal high flow therapy with nasal CPAP as a primary support, and it concluded that nasal high flow therapy is less effective than nasal CPAP in preventing treatment failure. Another RCT published in neonatal edition of Archives of Disease of Children in 2010 evaluated the clinical course, respiratory outcomes, and markers of inflammation in preterm infants less than 35 weeks with moderate RDS assigned from birth to either nasal CPAP or nasal BiPAP. It concluded that BiPAP was associated with better respiratory outcomes as compared to CPAP. Cochrane review published in 2017 compared effects of management with nasal IPPV versus nasal CPAP on the need for additional ventilatory support in preterm infants whose endotracheal tube was removed after a period of intermittent positive pressure ventilation. It concluded that NIPPV reduces the incidence of extubation failure and need for re-intubation more effectively than CPAP. So from these studies, we infer and summarize that nasal high flow therapy is easier to use and is associated with less risk of nasal trauma and pulmonary air leaks. Although effective and associated with less side effects, nasal high flow therapy is less effective than nasal CPAP in treatment of respiratory failure. As compared to nasal CPAP, nasal BiPAP has a better outcome and allowed earlier discharge. NIPPV is more effective than nasal CPAP in preventing extubation failures. Based on these conclusions, we suggest a stair model where, while initiating ventilatory assistance in a newborn, start from the safest type of NIV, that is nasal high flow therapy, and in case of signs of failure, step up the support to more effective one. Similarly, while weaning from invasive ventilation, we suggest stepping down to a type of NIV closest to effectiveness of invasive ventilation, and then gradually to the next lower steps. A practical approach to different types of NIV is given in next few slides. A neonate in type 2 respiratory failure but having spontaneous breathing is started on NIV in contrast to a neonate who has no or inadequate spontaneous breathing efforts and thus requires invasive ventilation. If NIV fails, then again the neonate will require invasive ventilation. In a spontaneously breathing neonate requiring ventilatory support, start with nasal high flow therapy at 4 liters per minute at FiO2 between 30 and 60%. In case a neonate improves and blood gases are stable, gradually wean the baby off ventilatory assistance. But in case he deteriorates as shown by his blood gases, gradually increase the support until he starts improving or to a maximum limit of high flow therapy before switching to nasal CPAP. We follow similar steps for CPAP. If a neonate improves, he is gradually weaned off to nasal high flow therapy, the lower step, and then so on. If he does not improve, then the ventilatory assistance is stepped up till either he starts improving or the limits are reached, where the support is stepped up to BiPAP. Similar are the steps for BiPAP ventilation. If a neonate improves, he is gradually weaned off to nasal CPAP, and then so on. If he does not improve, then the ventilatory assistance is stepped up till either he starts improving or the limit of BiPAP is reached, where the support is stepped up to nasal IPPV. If a neonate requires NIPP level support, we follow similar steps. If the neonate improves, he is gradually weaned off to nasal BiPAP, which is a lower step, and then so on. And if he does not improve, then the ventilatory assistance is stepped up till either he starts improving or the limit is reached, where the support is stepped up to invasive ventilation. While weaning from invasive ventilation, a neonate after extubation is put on secondary settings of NIPPV. If the neonate keeps on improving, he is gradually weaned off to nasal BiPAP, and then so on. If he does not improve, then the ventilatory assistance is stepped up till either he starts improving or if the limit is reached, where the support is again stepped up to invasive ventilation, which is basically extubation failure. This is the data of ventilated neonates from our neonatal unit that shows the trend of invasive and non-invasive ventilation over the last 5 years. In 2014, invasive ventilation was used in about 80% of our neonates requiring assisted ventilation. In the same year, we got HiPAP machine, a machine that can be converted in nasal high flow therapy as well as nasal CPAP just by changing the circuits. Since then, the trend has completely reversed. Data analysis in early 2020 showed complete reverse in trend. Now more than 80% of our neonates admitted in NICU requiring ventilatory assistance can be effectively managed with non-invasive ventilation, thus preventing many complications associated with invasive ventilation. So in summary, NIV refers to assisted ventilation through help of nasal prongs and mask. It avoids the complications associated with use of endotracheal tube. It improves ventilation through improvement in functional residual capacity. The types include nasal high flow therapy, CPAP, BiPAP, IPPV, high frequency ventilation, and NAVA. They are associated with less ventilator associated lung injuries. Nasal hypotherapy is associated with less risk of nasal trauma and pneumothorax. Nasal IPP is more effective in preventing extubation failures. Use of NIV is increasing in treatment of respiratory failure around the world. Thank you very much for your patient listening. I shall be very happy to answer the queries if there are any.
Irfan, for overview of non-invasive ventilation. So keeping the same pace and the same similar topic of less invasive or non-invasive. So what is going on in surfactant delivery approaches? So this is the topic of my talk, that less invasive surfactant delivery. So I will overview it. I'll go through some recent randomized controlled trials, CPAP and NIPPV with less invasive surfactant, how easy its implementation, and some long-term outcome. In generalization, if you can see that limiting invasive ventilation within is desirable. Of course, we don't need, as in previous talk, you heard about the adverse effect of invasive ventilation. So even when appropriately used, the invasive ventilation is not a good option unless and until we have in a dire situation. Imagine if we use inappropriately, they become unnecessary evil. Similarly, the non-invasive ventilation also has its own effects and effects. So the CPAP, for example, nasal trauma, pneumothoraces, NIPPV related to the bowel perforations, high flow nasal cannula infections, perforated eardrums, low flow nasal cannula, mucosal trauma, and so on and so forth. So we have to think something more, less invasive than this. So in Cochrane review 2007, I try to go always in a chronological order. So let's say 2007, almost 13 years ago, this is the Cochrane review. And they publish about the early surfactant administration with a brief ventilation versus selective surfactant and continued mechanical ventilation. So early surfactant with extubation to CPAP is better than invasive ventilation. We all know that. And surfactant by transient intubation using a low treatment, which is we called INSHO technique, low treatment threshold is preferable. And there are many trials on that, which showed that the CPAP alone is having a good result. The death on BPD is in the COIN trial, support trial, WARN CPAP, and WARN intubation, surfactant, and extubation trial. All are going in favor of non-invasive ventilation. But there are some complications also, especially if you see the COIN trial, the 9% having the pneumothorax. Now, the intubation, ventilation versus CPAP, we can easily say that the CPAP is better when the outcome is the risk of death or BPD. But what happened that if you don't give the surfactant or give the surfactant, so CPAP from birth without administration of the surfactant, and the lot of those trials show a lot of failures of the CPAP. So as I said before, this is again from the Dr. Peter Davis group, and they published in 2016, incidence and outcome of CPAP failure in preterm infants. And as you can see, the failure of the CPAP in 25 to 28 weeks is about 43%, and 29 to 32 weeks is about 21%. The CPAP failure was associated with a higher rate of pneumothorax, death, and bronchopulmonary dysplasia. So yes, it shows that CPAP is beneficial, but when it fails, it is really morbid condition, and we have to deal with this very sick baby. So the incidence of death or BPD was increased in the failure group of the CPAP. The surfactant replacement therapy, we all know prophylactic surfactant initially decrease the neonatal mortality, pneumothorax, and the PIE, and if you combine the BPD and the death. But initial, should we use prophylactic? Should we use early rescue or rescue? This is the question. So very early surfactant without mandatory ventilation in premature infant, treatment with early CPAP. This is a randomized controlled trial published in 2009, and quite a decent number, 279 infant, 27 to 31 week gestation with 15 to 60 minutes of age, and evidence of respiratory distress and treatment with oxygen in the delivery room. So they randomized to intubation, surfactant, and extubation to CPAP or CPAP alone group. Now, if you can see here that need for mechanical ventilation is clearly less in prophylactic surfactant, which is less than 0.05 probability. So it is statistically significant. Also, the air leak is statistically significant in the prophylactic surfactant group. But the surfactant more than 1 hour is the same, and chronic lung disease did not show any difference. So the intubation, ventilation versus insure technique, of course, insure technique show a little bit better outcome on death or BPD. If you combine insure versus alone the CPAP, many of the studies show nothing, no difference, but except the study which I showed you, which is called the ROHAS study. So if you combine all these things and see the risk of death or BPD at 36 weeks, the CurePAP, the ROHAS, and the VON study, the difference is not there as it crosses the confidence interval of 1. So similar finding of death and air leak. But I borrowed this slide from the Professor Ramanathan. He mentioned that if you use early insure plus nasal CPAP versus NIPPV, so you do the insure and put the baby on NIPPV in less than 30 weeks, they found a better result as compared to the CPAP with the NIPPV. So you give the insure technique, give the surfactant, and put the baby on NIPPV, then the mechanical ventilation need at 7 days is decreased, extubation failure is decreased, physiological BPD is also decreased, oxygen at 36 weeks as post-menstrual age is also decreased. Conclusion is for this initial summary is the non-invasive support, or is at least as effective as invasive support. Insure is not consistently superior to the CPAP alone. Long-term outcomes are still needed. So why less invasive surfactant delivery? So why it is come into the mind that if we can do deliver the surfactant more less invasive as insure, it means without tube, because there are infants failing insure are often intubated and mechanically ventilated. So same problem happening with the CPAP failure. So this is the data showed by Professor Ramanathan from Western California or the California, and it shows that the severe radiological grade and they are failing after the insure. So the hypothesis developed, would even less invasive surfactant administration to a spontaneously breathing neonate improve outcomes further? And it give many ideas. So give a pharyngeal administration via the laryngeal mask airway of surfactant, aerosolized surfactant, and thin catheter administration. I will focus on the thin catheter administration for this part of my talk. First of all, what is the difference between insure versus all these terms you use? LISA, which is less invasive surfactant administration, MIST, minimal invasive surfactant treatment, and less invasive surfactant treatment. So insure, we have to have laryngoscopy, same with the LISA. Need for PPV, yes, for insure technique, but LISA and LIST or all those less invasive required relies on spontaneous breathing. Endotracheal tube needed for that. For less invasive, we are using the thin catheters. I will come back on that. Is secure airway and must be careful with the LISA. Vocal cord position remains abducted because baby is intubated. Vocal cords can be adducted. in the less invasive. Sedative, often used when we are using Insure technique, less often used when we are doing less invasive method. More than 30 weeks, more tolerate the procedure of Insure, and extremely low gestational age babies can also tolerate the less invasive technique. The surfactant kinetics, the lung association of surfactant is less, and the dynamic compliance is low, but in less invasive method, better distribution and improve dynamic compliance. There are many techniques are going on. Cologne method, Sonshore, Take Care method, Hobart, and they are using different types of laryngoscope with Magel forceps, laryngoscope with no forceps, laryngoscope with no forceps, and so on and so forth. So whatever it is, you master it, you can do accordingly. There is a survey happened in Europe and published in 2018, because there is a catheter which is called LISA catheter, developed by the same company which is procuring the Curosurf. And they found it out that the most of those neonatologists from Austria, Belgium, Poland, Spain, and UK prefer to use this thin catheter as compared to the angiocath, which is in the red, and no difference, which is yellow, very few. So most of them are using the catheter, and they found it out it is easy to use as compared to the other catheters. Now come to the evidence. So what are the evidence right now? Initially, we have some non-randomized controlled trials started by Dr. Angela Krebs, who was the pioneer of this method from Germany. And there are many trials, but most of them are not that big, 29 babies, 150, then 319 babies, and then 164 babies. And they found some improvement, that lower prevalence of mechanical ventilation, less BPD as compared to the standard of care. So there are many non-randomized controlled trials through period of up till 2015. Then we have published randomized controlled trials for AMV trial, which is avoidance of mechanical ventilation, Take Care trial, NINSAP trial from German group, Mohammad Zadeh from Iran, and the Bao from China. And the primary outcome, need for any mechanical ventilation or being not ventilated but having PCO2 more than 65 mmHg, need for early mechanical ventilation, survival without BPD, need for mechanical ventilation, and duration of oxygen therapy. So randomized controlled trials of thin catheter administration, these are some outcomes. So in 2015, from China, they found there is no difference in the mechanical ventilation in the first 72 hours BPD pneumothorax. So they couldn't find any difference. From Turkey, there is a trial in 2013, and they found it out rate of mechanical ventilation in the first 72 hours of life and BPD lower in the thin catheter administration. Similar, from the Iran, the 3-center trial said that the mortality lower in the thin catheter administration group. Another trial from Iran showing the similar kind of results. But the major trial from 2011 to 2017, which has a lot of the babies and the multi-center trials, one from the Germany with 12 hospitals, is called Avoiding of Mechanical Ventilation. And they clearly found it out that lower rate of intubation with the thin catheter group intubation as compared to the intubation group, no difference in mortality, pneumothorax, or BPD. Angela Krebs trial, which is an NSAP called non-intubated surfactant application, is a reduction in absolute risk of survival without BPD and pneumothorax in the TCA group compared with the selective intubation. And Oliver from Canada, the 3-hospital trial, also found it out the absolute risk reduction in the need for mechanical ventilation on pneumothorax. There is another trial published in 2016, and it is interesting. So that's why I put it in my talk. It is published in JAMA in 2016 by Isayama and his group. He compared association of non-invasive ventilation strategies with mortality and BPD among preterm infants. So first he showed, compared with the mechanical ventilation, LISA had a lower rate of primary outcome. So the odd ratio is 0.49 and BPD is 0.53. And as you can see, the confidence interval not crossing the line of 1. And compared with the CPAP also, LISA had a lower rate of primary outcome. So he compared the LISA technique with the mechanical ventilation and both with the CPAP. And interestingly, he put it as a ranking probability of the strategies. So which one is the best one is the one, and so on and so forth. So as you can see in the first outcome, which is death and or chronic lung disease, he thinks LISA is a ranking median is number 1. So it means that there's a very high probability with the LISA to have a very few deaths or the chronic lung disease. Similarly, alone the bronchopulmonary dysplasia, the LISA acquire the number 1 position as compared to the other. The BPD with the second is the INSURE, third is the NIPV, and nasal CPAP alone is the 4th. So these are the ranking strategies, just get my attention to that. So overall, in 2016, again, the LISA versus INSURE is published, and they found it out: BPD all patient, BPD in survivor, death or BPD early nasal CPAP, any mechanical ventilation and any mechanical ventilation reported, all goes in favor of LISA. The other morbidities, there is no difference in PDA, NEC, severe IVH, death or other morbidities. The only thing is the last one, which is the surfactant reflex. Of course, this is the technique you have to learn and to master it, to go it slowly. I will come into in a minute to that. Another one from the Alberta, Canada, the similar type of the result showed, it's published in 2017 in Archive Disease of Childhood, and they found it out that for BPD at 36 weeks is better in LISA, BPD at 36 weeks in survivor less in LISA, mechanical ventilation and mechanical ventilation less than 72 hours or any time is less than in LISA technique. And of course, the surfactant reflex is there. There are some risk factors. Again, I recently borrowed these slides from Dr. Ramanathan. He published in Fetal and Neonatal Medicine in April 2009. There are some failures of this less invasive techniques. And it has some variables that if you fulfill those criteria, then the chances of success is high. So for example, if a surfactant dose less than 200 milligram, the chances of failure of this technique is high. If no antenatal steroid, then the chances of failure is high. If there is infection and severe infection, although it's not statistically significant, but still the chances of failure is high. Oxygen before miss is no difference. IVH grade 2, if it is already there, then the chances of failure is high and is statistically significant. So I think this study gave us some idea that which baby which we select for this technique. So the baby who just came and deliver or pop out without any antenatal steroid, don't have proper antenatal care, I think this is not the candidate for the LISA technique. The second question arises that at what FiO2 we should give surfactant, at 30% or 40% or 0.3 or 0.4. So there are two variables in this, a modeling cohort and validation cohort. And they find it out that the maximum FiO2, 30% and above, it is significant, and it shows that in the second hour, if you have a 30% or more FiO2, the chances of your CPAP alone failure is very high. And also you can add up with the radiographic severe RDS predicted. So this is very good, give you a very good idea that this candidate can be a good candidate for the LISA technique. Similarly, last year, very comprehensive guidelines published, and Dr. Ola Sagastad, which is also our speaker tomorrow, also the part of this guidelines, and what they recommend how to treat the RDS. The CPAP with early rescue surfactant is considered optimal management for babies with RDS. So A1, which is a very high level of evidence. Babies with RDS should be given rescue surfactant early in the course of the disease, and it is again showing the 30% or above, you should give the surfactant, and it is evidence level of B2, which is moderate. And LISA is the preferred method to give the surfactant, and again, the evidence is B2, which is moderately good evidence. Now, we have the evidence that LISA has some effect and some better effect. Then the question arises that, okay, you are doing with the some catheters, is the implementation is difficult or not? So this is a study published from Poland, experience of a mid-sized country, the implementation of less invasive surfactant administration, and it is just published in July 2020. What they did, they take two groups, one the resident, which is early in their career, and the one is specialist, which are the mid in their career. And most of them, they said it is easy and it is easy to learn and it is not difficult to implement. Also in this graph, they showed in different quarters when they get more training and more education, the 76% of those are saying this is easy technique to implement. So they conclude that the LISA procedure does not appear to be technically difficult to master. Training combining theory with practical exercise is an efficient implementation strategy. Similar study just published in April to 2020 in Scotland. They put in level 3 unit, and they said that we have successfully introduced the LISA technique into our department, and 72% of the patient in our series did intubation and ventilation. So what is going on right now around the world who are using these techniques? Mostly in the European countries, as you can see that in this graph, it is starting almost the 2000 and then 2010 and 12 and in 14, there's a steep up in that. So there's an online questionnaire, 37 European countries, 51 response rate, 52% using LISA, 41% standard procedure for surfactant administration. Also in the UK, the similar result, they are using a lot, and LISA was used regularly in 35, which is 19% units in the UK, and most of them giving surfactant at 30% oxygen. And they are using in a very low, very small babies also. The North America, or the American actually, because this is the study done by one of my fellows, Dr. Shahana, and she published in 2019 in Journal of Perinatology, and there is still some doubts in the USA to use this technique, and they need more evidence. So either they are using as a research purposes, or unlike several regions of Europe, LISA is not widely used as in the US. So still there are some questioning about that in the North America. But this technique also has some troubles. And what are the troubleshooters? So if the baby has bradycardia desaturation during technique, many of them using atropine. But when we were using it, we are not giving anything, and we don't have faced this problem. Apnea, the caffeine we use very early, right away after the birth. So this is one of the reason we didn't get that problem. LISA, if it is failed on first time, they start using sedation. Depth of insertion depth is from the Melbourne. They said is 1.5 centimeter for less than 27 weeks and 2 centimeter for all other babies is quite enough. If dislodge the catheter, you can check it with the easy cap carbon dioxide detector. If it is coughing and gagging, then slow administration needed. So for the reflex, there are many things, many different units are doing, but to give it in a very slow manner, over 2 to 3 minutes, it will solve this problem. Improving LISA success, and we always doing that whenever we do the LISA, we put the baby of NIPPV as compared to the CPAP. Now the outcome, which is published only by the one center so far, but there are many other studies going on. It is from the University of Vienna. Their group is 23, 27 week, the LISA cohort, and quite a big number of LISA cohort, 557. And they found it out that 26% is normal, 22.8% is a mild impairment, moderate impairment is 13.1, and the severe is 4.7. But the death is 18.3% as compared to the 41.1% in the control. So it's a very encouraging result. Similar results at the 5 years LISA group, they use 23 weeks to up to 27 weeks. The total number is 236. And they've mentioned it's 76% at 5 years when they do the cognition scores by using these two scores, KBC and KBC2, and they found that 76% is normal, only 14% get mild, and 5% moderate and severe in each group. So they conclude that not only increased survival, but also increased survival with favorable neurodevelopmental outcome after LISA in the Vienna. This one is just published in April 2020, the less invasive surfactant administration best practice and an answer question. They just put the commentary on that maintenance of spontaneous breathing with support by the LISA technique holds big promise. Patient comfort and lower complication rates are strong. Arguments, open question include exact indication, as we just said, that which baby is fit for this technique, the issue of analgesia and sedation during the procedure, and studies on the long-term outcome is still going on. So just to conclude my talk, again, this is the slide from Professor Ramanathan, the surfactant therapy, past, present, and future. In 1980, we don't have the animal surfactant. We have only synthetic, which is Exosurf, which has not that great efficacy, prophylaxis versus early, the surfactant treatment in intubated patient, and at that time, we are mostly intubating all the patient. Then in 1990 to 2020s, we start with the non-invasive, then insure technique, then LISA technique, and we come to know that no prophylactic surfactant treatment with increasing antenatal steroid use. Future can be the LISA plus NIPPV or intubation, rescue surfactant and extubation, or the non-invasive surfactant treatment, which is the inhaled surfactant or nebulization. 4 major interventions to manage RDS in very low birth and extremely low birth weight baby: antenatal steroid, nasal CPAP, or NIPPV plus early rescue surfactant by the LISA plus caffeine, early caffeine as much as possible. So to summary, the increased using of CPAP as initial respiratory therapy of preterm infant with the RDS raised the question whether surfactant application during CPAP is possible. The answer is yes, it is possible and it is effective. The number of studies demonstrate the feasibility of surfactant application during CPAP or NIPPV via thin endotracheal catheter lead to the hypothesis that the method may be beneficial, and as I showed you, there are many randomized controlled trials show its benefit. RCTs demonstrates an effect on the need of for mechanical ventilation. Yes, it showed that it reduced the use of mechanical ventilations. And reduction of neonatal complications seems possible. Again, the answer is yes. Positive effect on neurological and respiratory outcome, as much as we know from the Vienna group, it is a positive effect that there is no neurodevelopmental delay or derangement in the LISA group, but still the large cohort is needed, and the studies are studies are going on. With that, I will finish my talk, and then we'll go through the question answer session. I hope Dr. Peter Davis with us, and I hope that Dr. Irfan is also joined with us. I have a series of questions.
Doctor,
Yes.
just one more.
Okay. So again, once again, thank you, Irfan, and thank you, Dr. Peter Davis. We have quite a few questions, and I will try my best to cover all of those. So there's the first question, actually, because I am the last, is for me, but I will direct to Dr. Peter Davis. So what do you think that LISA is a standard of care now? So the answer from my side is no. But I want the comment of Dr. Peter Davis on this question also.
It's a very difficult question, Junaid. I wonder if we can stop screen sharing. But yeah, it's always interesting when half the world thinks it's better than it's very good, and half the world is still suspicious. We're still waiting for the result of our 400 baby optimist trial to help resolve this question. So the large randomized trial that you were looking for. So particularly for our small babies, our babies under 30 weeks, we're still waiting for that trial to be analysed. It's completed recruitment. Analysis is now proceeding. In the meantime, we're quite comfortable using the LISA procedure for our slightly bigger babies. But as you suggested, as evidence points, we tend to leave that procedure to our more experienced operators, which makes it difficult for our young people to learn their craft of learning to intubate babies. We use the video laryngoscope to help them do that. We like to give atropine to keep the heart rate up while we give the LISA, and so we're slowly creeping into that LISA world.
Okay, so you are doing as a procedure of choice, huh, Doctor? Yeah.
For babies beyond 28 weeks, if they get it or more than 30% on CPAP, we would try a LISA procedure. Yep.
Okay. So there's a question for Irfan. Irfan, you are listening?
Yes, I am.
Okay. What is the maximum recommended PIP and I time that can use in NIPPV? This is one of the participant said.
For NIPP, it's recommended about 22 centimeters of water.
Okay. And
I time ranges between 0.5 seconds to 2 seconds.
Okay. So this is the same question to Dr. Peter Davis also, that do you use NIPPV or CPAP in a very small babies, less than 27 weeks? What your preference?
We use CPAP as our first line treatment, and we would sometimes use NIPPV for babies who were failing therapy with CPAP. Unfortunately, we don't have access to synchronized NIPPV, and we think that's probably important. I suspect that the benefits from unsynchronized NIPPV are largely due to an increased mean airway pressure that Dr. Irfan talked about, that certainly improves oxygenation, and it probably allows us to deliver higher mean airway pressures than we would otherwise be comfortable giving with just CPAP. So CPAP's above 8, 9 or 10.
Sure. So as we are talking about the same topic, so again, Irfan, this is a question for you, but I need a comment for Dr. Davis also, that with slow increase in respiratory support from nasal cannula to intubation with invasive ventilation, isn't there a chance for allowing the RDS to progress? Why not start with CPAP or nasal IMV?
It is again the same that I presented earlier. Nasal cannula is safer. So you don't know about the patient that whether this baby, this particular baby will benefit from only high flow or would need CPAP. The actual in practical approach, we need to be quick from switching from one to another. So we have to be on guard till the baby stabilizes.
Okay.
We would not let a baby deteriorate at any time.
So, Dr. Peter Davis, you presented once about the high flow nasal cannula inferiority trial, but you suggest that not to give, this is the first choice of the treatment in a baby. You start with CPAP and then you can wean to high flow. Isn't right?
We've done some more thinking and research on that topic, Junaid, and it's quite interesting. We use what we call the 30-30 rule. So we are happy to start high flow if the baby is in less than 30% oxygen and more than 30 weeks gestation. So the bigger baby with the mild disease, it's consistent with what Dr. Irfan was suggesting. Those babies we're comfortable with starting on high flow, keeping CPAP if they deteriorate. For the smaller babies, yes, get right on top of them, keep their lungs open, and CPAP is more effective.
Okay. So same topic related is another very interesting question, and it is happening in our unit because our nurses are doing that is there any role of air oxygen flow less than 1 liter during weaning? Okay, decrease 0.5, then 0.25. What do you think, both of you?
Peter Davis first, please. You can go on.
Peter, yes.
It's I'm not sure how many nurses are in on the meeting, Junaid, but as we all know, nurses rule the world, and it's important that they are kept happy. So yes, we do end up, we don't, well, let me start by saying we don't use high flow less than 4 liters per minute. So when we're down below that, we use unhumidified low flow oxygen, and we will get down to 100 mils, 80, 60, 40 mils of subnasal oxygen for those little babies who just need a whiff, we say, a whiff of oxygen to keep their saturations in the target range. Now, when you translate that to an FiO2, we're probably giving them in the 22 to 23% mark, so very little, but it just seems to be enough to keep their saturations in a range where we're comfortable. It probably helps their apneas as well. But I'd be interested in your thoughts.
Sure.
I absolutely agree with you.
Yeah.
But
yes, go ahead.
we switch from CPAP to high flow at 2 liters. We come down to 2 liters. And because by definition, low flow is less than 1 liter, then we switch on once we reach 2 liters of flow, then we come down to low flow oxygen, which is not technically a non-invasive ventilation.
So again, there is a question, Dr. Peter Davis, for you, that what is the maximum PEEP that can be used in the delivery room?
Yes, well, this is a very interesting question, and again, a wide geographical spread. Many American units will use 5 centimeters of water. Rich Poland, a frequent guest in Abu Dhabi, his unit would standardly use 5 centimeters, occasionally go to 6. We're a little bit more liberal, and particularly early on, to get the baby's lungs expanded, we may start at 7 and go to 8. You mentioned in your talk that we saw an increased rate of pneumothorax in the COIN trial, and
yes.
in that trial we did take the CPAP level up to 10, And my personal belief is that probably was associated with the increased risk of pneumothorax. So we've come back from that, but still using up to 7 or 8 centimeters of water of CPAP in the delivery room.
Okay. There's another question about the delayed cord clamping. What about can we perform delayed cord clamping in placental abruptio or previa? If no, then it should also be added in the definition. What about delayed cord clamping in twins or multiple gestations? So there are two questions about abruptio and multiple gestations and clamping.
Very, very good questions. And as you intimated, we're discussing this at the ILCOR group at the moment. And those two specific groups, multiple pregnancies and abruption, go into our gaps in the knowledge section. But for those babies, we would not be recommending delayed cord clamping at this stage.
Okay. Okay. Yes.
If you would allow me to comment on the previous question.
Yeah.
What Peter Davies has said about the CPAP in delivery room.
Yes.
Sorry, PEEP in the delivery room. If you go into the basics, I mean the basics of physics.
Yes.
Probably, I agree what Peter Davies has said. But the smaller the tube is, I mean the smaller the baby is, probably we would need to give a little higher PEEP as compared to if we are using a larger bore endotracheal tube, if it's an endotracheal tube.
But
what if you're doing it directly through mask, but that's different then.
Okay, so that's the question, that if you are using the CPAP, then how much maximum PEEP you can give?
In a smaller baby with endotracheal tube, a little higher PEEP, maybe 7-8 centimeter. But on the other end, it will not be delivered 7-8. It will be less than that. But if the tube is larger, or if we are giving it through face mask, then a lower PEEP, as Peter Davies has said. Maybe
Okay.
6.
This is a question for me, but I love to have comments of both. LISA can be done by the CuraSurf or can be done by any surfactant because of the amount. I did with other surfactant also, and we don't have any big problem with that. I need your comment, Dr. Peter Davis.
Yes, our experience is limited to CuraSurf because that's what we've got available. We're quite glad to have that small volume, but I don't have any experience with other forms of surfactant. Okay.
Irfan, do you have any experience with CuraSurf or no?
Yes, we have experience with CuraSurf, but not with LISA technique.
Okay. Okay. The other question is that I think it is coming from the Pakistan, that if the LISA technique is good and avoiding the mechanical ventilation, so it is not better to, in a low income countries, can we use it? Irfan, your comment on that?
Why not? It can be used, but the point is, as Peter Davies has already mentioned, and you have already mentioned, that till we reach 30% of FiO2 and a pressure of 6 centimeter, and that's an evidence-based recommendation. We should not give surfactant. After that, of course, LISA can be used if you are trained in that technique.
Okay. So I think the participant asked that can we do the training and experience in that technique? That's the whole point.
Why not? Yes, I don't see any bar on that.
Okay. I'm sorry taking your time, because still we have time, and second paper came for the questions. So bear with me.
Welcome.
Okay.
Welcome.
Okay. So Dr. Peter Davis, what about the use of NIPPV in labor ward?
We haven't tried NIPPV in the delivery room. That's an interesting topic, but it may be a little bit. We like to keep things simple in the delivery room, so I'd be a little bit unclear about whether NIPPV would be indicated. I'd be interested if either of you have used it.
Not in delivery room. I haven't read anything about any evidence for that.
Yeah, exactly. So we don't use the NIPP. Okay, again, the question for actually both of you, what is the maximum flow with the high flow nasal cannula? Is it according to the weight? Or it is according to the weight? I think the typing.
It is according to the weight. If it is baby is more than 1 kilogram, the maximum is 8 liters per minute, and less than 1 kg, it's 6.
Dr. Peter?
Yeah,
Liters per minute.
we're a little bit braver than that. The device that we use, the Fisher and Paykel prongs, will allow us to go up to 8 liters for all babies. I understand they're developing prongs that they believe are safe that will deliver higher flows. We're reassured by the lack of pneumothorax in all of the high flow trials, and so we think perhaps the flow rates will end up being higher, but for the moment 8 is our maximum.
Okay, so the question about Lisa again, what is the best analgesia before Lisa? What you are using, Peter?
We just use sucrose, I'm afraid, and
Same.
This is the big ethical question, isn't it? We've decided it's unethical to intubate babies without sedation and muscle relaxation. Yet we're still using the big laryngoscope down their throats. It must be terribly uncomfortable. So it's a difficult question. We don't have any answer. The obvious problem with sedating these babies is they stop breathing and you end up having to intubate them to support them. So that's sort of defeating the purpose.
Exactly. The same thing happened with us. We use only the sucrose. We don't use, because once we use the morphine or something else and it start desaturating and we end up in the intubation even before we start this procedure of Lisa. Okay. I think this is the same question. Irfan, you already answered that the maximum flow safely can be used through high flow in a babies with 1 kilogram and less.
Yeah, 6 and 8.
6 and 8.
I just answered that.
Yeah. It's the same question. The last question about Dr. Peter and Irfan. Can we have to use some sedation or some analgesia, as you said about the intubation and this thing, before we are giving the Lisa? We have to use it, or because there's two different questions. One asking about best analgesia and one asking, do we have to use it or not? You got my point. We answer already, but this is again, if you can.
Yeah.
I think, again, Peter first.
Yes. Okay, Peter, you're the first.
Yeah, we as I said, we use sucrose with most of our babies in this situation. We don't use anything stronger than that. We feel a little bit uncomfortable. We're reassured that our nurses, who are good advocates for the babies, seem comfortable with this procedure. It's another argument for getting your best operator in on the job. Get the job done quickly. Laryngoscope in, catheter in, laryngoscope out as fast as possible to minimize the baby's discomfort. But that's how we rationalize it.
Okay.
I agree.
Okay, thank you very much, Dr. Irfan, Dr. Peter Davis. A very nice session. Thanks a lot for both of you, for your experience and for your comments and this panel discussion. Peter, I will see you inshallah tomorrow again. And Irfan, hopefully you have some time to join us again tomorrow with the session.
Thank you very much.
Thank you. So inshallah we'll see you. Thanks a lot, both of you.
Thanks, Junaid.
Thank you.
Very much enjoyed it.
Thanks a lot.
Here, once you find yourself here, you are here, right? Yeah. Once you see